This is part 2 of a guide to clinical reasoning, or how to create an accurate differential diagnosis from a patient's presentation. In the first part, I reviewed a practical 5-step bedside approach to clinical reasoning. Here it is to remind you. In this part, I will demonstrate how to use this approach with an actual patient case at the student level. I'll present this patient to you the same way an intern might present the patient to his or her attending on rounds, or to their colleagues during a morning report or teaching conference. As I present the case, I'll keep a running list of the key features of the presentation, so it will seem like I am doing step 1, acquire data, and step 2, identified key features, concurrently rather than sequentially. In reality, most trainees would probably wait to identify those key features until after the presentation was completely over and the complete case was known. But as a trainee gains experience, he or she will improve their ability to do all these steps simultaneously. If you are looking to practice, try listening to the presentation without watching it and writing down what seem like the key features to you as you hear them. For the chief complaint, the patient is a 75-year-old woman presenting with epigastric pain for 4 hours. Mrs. Smith is a 75-year-old woman with a history of smoking and moderate alcohol use who was in her usual state of health until 4 hours prior to presentation, at which time she developed the onset of abdominal pain. The pain is relatively well localized to the midline in the region between her umbilicus and xiphoid process. There did not seem to be any particular trigger, and the duration from initial onset to its maximal intensity of 8 out of 10 was about 45 minutes. The pain is constant, does not radiate, is not exacerbated by anything, including exertion, nor alleviated by anything. She had moderate nausea and has refused to attempt to eat or drink anything since the pain's onset because she is concerned that it will cause her to vomit, which she has not yet done. She denies changes in her bowel habits, shortness of breath, chest pain, changes in skin or eye color. Her past medical history is notable for hypertension and diabetes. She has had no surgeries. Her medications include hydrochlorothiazide 25 milligrams daily, amlodipine 5 milligrams daily, metformin 500 milligrams BID, omeprazole 20 milligrams daily, thiamine 100 milligrams daily, and folate 1 milligram daily. In her social history, she currently lives with her husband in a small community in the Santa Cruz Mountains. She is a retired horse trainer. She drinks 3 to 4 alcoholic beverages a night, but denies any history of withdrawal symptoms. She has smoked 1 pack per day for 40 years. For her family history, her father died at 85 from a heart attack, and her mother at 68 from breast cancer. She has had no siblings. When asked if she has any particular theories or concerns as to what is causing her symptoms, she says she has no idea, but her husband is concerned about contamination from a new well that was drilled on their property for drinking water 1 week ago. On exam, she is an elderly woman, appears her stated age, in moderate discomfort secondary to abdominal pain. Her temperature is 99.8, heart rate 110, blood pressure 132/80, respiratory rate 26, and oxygen saturation of 98% on room air. HEENT exam reveals normal oral pharynx but poor dentition. Her neck is supple, without bruits and without lymphadenopathy. Her chest is clear to percussion and auscultation bilaterally. Her cardiac exam has a regular tachycardia, hyperdynamic sounds, no S3 or S4, and no murmurs. Her JVP is undetectable at either 45 degrees or when she's completely supine. On abdominal exam, she is non-distended and there are no scars. She has normal resonance to percussion. The abdomen was soft and there was no rebound tenderness. She has marked tenderness, however, to light palpation in the epigastric region and mild tenderness in the periumbilical region. She declined deep palpation. There are no masses noted. Liver edge is 1 centimeter below the costal margin and non-tender. She declined examination of the spleen due to the fear of exacerbating her pain. Bowel sounds are unusually quiet but present. Rectal exam with normal tone, no tenderness, and minimal guaiac negative brown stool. Musculoskeletal exam revealed full range of motion in all joints without bony abnormalities. There is no edema or clubbing in her extremities. On neural exam, she was oriented to person, place, time, and situation. She was fully conversant and appropriate. Speech and language normal. Thought process normal. Cranial nerves 2 through 12 normal. Patellar and brachial reflexes 1+ bilaterally. Thorough strength testing and gait were deferred due to patient discomfort and exam fatigue. For her labs, her CBC revealed a white blood cell count of 15 with 85% neutrophils. Her hemoglobin was 14.5 and platelets were 325. Basic metabolic panel was normal. LFTs notable for a total bilirubin slightly elevated at 2.5, all of which was indirect. Amylase was slightly elevated at 135 and lipase elevated at 110. CK and troponin are normal. A urinalysis is normal. An EKG just shows sinus tachycardia with no other abnormalities. CT scan of the abdomen and pelvis has been ordered, but not yet completed.
So let's review what I've identified as key features, remembering that these are the individual elements of the presentation that we expect will allow us to differentiate one diagnosis from another. The patient is a 75-year-old woman with abdominal pain for 4 hours. It is epigastric, well localized, progressed over 45 minutes, is constant, with no exacerbating or alleviating factors, and associated with nausea. From the rest of her history, she has hypertension, diabetes, moderate alcohol use, smoking, and is drinking water from a newly drilled well. On exam, she is in moderate distress. She has a borderline temperature, tachycardia and tachypnea. She has a non-distended abdomen that was soft with no rebound, severe epigastric tenderness, and guaiac negative. The key test results are a white blood cell count of 15, normal basic metabolic panel, mildly increased indirect bilirubin, modestly elevated lipase, normal troponin and CK, and an EKG with only sinus tachycardia. If we return to our 5-step approach, we see that the next step is creating the problem representation. Remember that the problem representation is a 1 to 2 sentence summary using precise medical terminology of the most highly relevant aspects of the patient's history, exam, and diagnostic tests. That is, a summary of the most important of the key features. Which of the key features seem the absolutely most important? Obviously, this is a matter of judgment and opinion, but here is mine. And to quickly review the structure of the problem representation, which as noted in the part 1 of this video is also sometimes referred to as the summary statement or the impression. The problem representation starts with the age and gender, then the highly relevant past medical history, then the primary symptom using semantic qualifiers, and ending with the highly relevant diagnostic data using clinical syndromes when possible. So for this patient, we would start with Mrs. Smith is a 75-year-old woman. Then for the highly relevant past medical history, I would probably include the hypertension, diabetes, and smoking, which gets summarized as multiple cardiovascular risk factors, and the alcohol use. The primary symptom using semantic qualifiers might sound something like acute constant epigastric pain. And finally, for the relevant diagnostic data, we would group together the white blood cell count, borderline fever, tachycardia, and tachypnea as SIRS, or the Systemic Inflammatory Response Syndrome. We would mention the epigastric tenderness since it was so prominent and was directly related to the chief complaint. The soft abdomen and lack of rebound would be grouped into the collective descriptor of absent peritoneal signs. And given its high relevance to one of the leading diagnoses, we would also include the elevated lipase. So altogether, Mrs. Smith is a 75-year-old woman with multiple cardiovascular risk factors and alcohol use, presenting with acute constant epigastric pain, who is found to have SIRS, severe epigastric tenderness without peritoneal signs, and an elevated lipase. The next time you are in rounds or in a teaching conference, and the senior physician asks you to summarize the case, If a statement similar to this one effortlessly comes out of your mouth, I guarantee you everyone in the room will be impressed. So now step 4, adopt a framework. As I discussed in part 1 of this video series, no problem representation has only one correct framework. The organization of a particular framework may just appeal more to some people than others. In general, when the primary problem is some form of abdominal pain, most people find an anatomic framework works best, particularly one which subdivides the abdomen into quadrants or regions in which a disease of a specific organ is listed within the region under which it lies. So for this patient with epigastric pain, the epigastrum would obviously be the most critical anatomic region to include. Organs that physically lie directly underneath the epigastric area include the stomach, pancreas, and small bowel. Diseases of the stomach which cause acute abdominal pain are many, but most commonly are gastritis and peptic ulcer disease. In the pancreas, we have acute pancreatitis, and diseases of the small bowel that can cause acute epigastric pain include relatively common and minor things such as food poisoning and gastroenteritis, and the uncommon but potentially lethal problem of bowel infarction. In addition to epigastric structures, structures that physically sit within the right and left upper quadrants can cause pain that appears to originate from the epigastrum. This is known as referred pain. So therefore, we should also include the right and left upper quadrants in our anatomy-based framework. In the right upper quadrant, the major structures are, of course, the liver and gallbladder, along with other components of the extrahepatic biliary system. The liver can cause pain with either hepatitis or a hepatic abscess.
The biliary system can cause pain with inflammation or infection of the gallbladder, known as cholecystitis.
Inflammation or infection of the bile ducts, known as cholangitis, or intermittent obstruction of the bile ducts without inflammation or infection, a condition known as biliary colic. In the left upper quadrant, there is really just one unaccounted organ, the spleen. The spleen can cause pain with either a splenic infarct or a splenic abscess. This particular list is not meant to be unusually comprehensive. For example, I have not included the transverse colon, which crosses through the epigastrum, though pain in the transverse colon more typically is localized to the periumbilical region. Also because structures in the lower quadrants and retroperitoneal space can, on rare occasion, radiate to the upper abdomen. If one wanted to be unusually thorough with a framework, one could also include structures and diagnoses such as appendicitis in the right lower quadrant, diverticulitis in the left lower quadrant, and even a dissection of the abdominal aorta in the retroperitoneum. Though the presentation does not really suggest any of these, in the framework stage the goal is to produce a structured list of diagnoses for the general problem representation without yet applying specific key features. One non-epigastric and in fact non-abdominal region that I would definitely also include in this framework is the chest. Referred pain to the upper abdomen from intrathoracic diseases is a common phenomenon. Organs in the chest to consider include the esophagus, from which pain classically radiates to the epigastric area, as in GERD. The heart can also refer pain to the epigastric region, as seen in acute coronary syndrome, that is either unstable angina or an MI. Finally, the lungs. Pain from a pulmonary embolism can be referred to the abdomen, although it more typically is to the right or left upper quadrants and not the epigastrum. Now that we have a framework, we move on to the final and hardest step, applying the key features to that framework. So here's our framework once again, and here are our key features. How does one start this process? The brute force method would simply be to take each diagnosis listed one at a time and review each individual key feature to decide if it impacted the probability of the diagnosis and what that impact was. That is obviously very tedious and time-consuming. An expert clinician would probably start with the key features, focusing on the ones that were either most prominent, most unusual, or those which clearly clustered together. then thinking about which specific diagnoses were impacted by those features. For the purposes of demonstration, I'm going to take an approach here somewhere in between by going through each diagnosis one at a time, but only mentioning those key features which seem particularly relevant. So first up is gastritis. The patient has some risk factors for gastritis with her alcohol use and smoking, so these increase the probability of this diagnosis. Also, gastritis can be associated with nausea. Arguing against this diagnosis is the borderline fever, which gastritis does not cause, along with the leukocytosis and elevated lipase. And she simply sounds just a little bit too sick for this diagnosis. Then there is PUD. In the absence of an ulcer perforation, there is not a very reliable means of distinguishing PUD from gastritis on clinical grounds. In other words, the arguments for and against PUD are essentially the same as that for gastritis, with the exception that alcohol may be less of a prominent risk factor for PUD as it was for gastritis. Pancreatitis. The alcohol use is definitely a risk factor here, which argues for the diagnosis. Pancreatitis is also usually associated with a systemic inflammatory response syndrome, with its elevated temperature, heart rate, and white blood cell count, along with a severe epigastric tenderness. The elevated lipase is thought to be a relatively specific finding for pancreatitis, increasing the probability of the diagnosis, though the degree of elevation isn't so great as to eliminate other possibilities. Acute pancreatitis is almost always associated with nausea, and severe nausea at that, so the presence of nausea here definitely argues in favor of the diagnosis. Arguing just modestly against pancreatitis is the fact that the pain had no exacerbating or alleviating factors. The pain from pancreatitis classically improves with sitting up or leaning forward, which this patient does not describe. However, the sensitivity and specificity of this symptom feature, to the best of my knowledge, has never been studied. Therefore, we don't know exactly how much to weigh this in our assessment of the probability of pancreatitis, though using my experience and gestalt, I would place relatively little weight on the lack of a positional component to the symptom. How about food poisoning and gastroenteritis? And so we are on the same page. Most American doctors use the term food poisoning to refer to consumption of food contaminated with preformed bacterial toxins, such as that from Staph aureus or Bacillus cereus. We use gastroenteritis to refer to a condition when the patient has actually contracted an active infectious disease of the gut, which in developed countries is usually viral, occasionally bacterial, and only rarely protozoan. Keep in mind that this distinction between the two diagnoses may be different in your geographic region. So for food poisoning, the association with nausea is an argument in favor, although the lack of vomiting is atypical. Unlike gastroenteritis, the lack of diarrhea is not inconsistent with food poisoning. Although one might speculate that the new well could be a risk factor for this diagnosis, well water does not become contaminated with preformed bacterial toxins the same way that food sitting out at a sketchy salad bar might. One argument against food poisoning includes her SIRS physiology. Food poisoning can cause a number of these vital sign findings, but usually as a consequence of severe dehydration from vomiting, which she has not been doing. It also is not typically associated with a high lipase. With gastroenteritis, once again the nausea argues in favor, but this time the lack of diarrhea argues against. Wells certainly can become contaminated with enteric bacteria, but for this to happen with a brand new well, it would imply that they literally drilled it into a patch of pre-inoculated earth, which, without knowing more details about the well's location, seems quite unlikely. Depending upon the specific pathogen, her severity of illness could certainly be consistent with a severe form of this, but as with most diagnoses on here, gastroenteritis is not thought to typically cause a high lipase. For a bowel infarction, her cardiovascular risk factors put her at risk of this. This would definitely result in constant pain, appearance of distress, SIRS, and can even cause an elevated lipase. Really, a bowel infarction would explain her presentation quite well, except for the fact that a bowel infarction is relatively uncommon compared to most other diagnoses listed. A key feature that would help further assess this possibility is the presence or absence of an elevated lactate, which was not mentioned in the presentation, though the normal basic metabolic panel suggests that there is not an elevated anion gap acidosis present, and that sort of argues a bit against the Ballen-Farkshan diagnosis. I'll be pretty quick with the organs in the right and left upper quadrants because the presentation doesn't particularly support any of them. The unremarkable LFTs in and of themselves rule out acute hepatitis. Hepatic abscess usually has symptoms localized to the right upper quadrant and is also associated with LFT abnormalities and a normal lipase. Cholecystitis also typically causes right upper quadrant symptoms and signs, particularly right upper quadrant tenderness, along with elevated alkaline phosphatase. Although it's not enough to make the diagnosis likely enough to seriously consider at this point, acute cholecystitis has been described as a cause of elevated lipase. The same analysis for cholecystitis holds true for cholangitis, with the additional negative argument that the patient has no elevation of direct or conjugated bilirubin, that is, no evidence of jaundice. The patient is simply too sick appearing for this to be biliary colic. Plus, as its very name implies, the pain from this usually waxes and wanes instead of being constant. The patient has risk factors for a splenic infarct, though this usually does not radiate to the epigastric area and is a relatively rare diagnosis. Same for a splenic abscess. Moving into the chest, the acuity and severity of illness rules out GERD. For acute coronary syndrome, the patient does have numerous risk factors, and the combination of epigastric pain and nausea is not an uncommon way for ACS to present, particularly in either a woman or a diabetic. The major thing which does not fit is the severe epigastric tenderness. Since the epigastric pain is referred from the chest, the abdomen itself should not necessarily be particularly tender. Finally, a pulmonary embolism can cause abdominal pain, but as with ACS, would not be expected to cause abdominal tenderness. Also, the patient has no major risk factors for a PE and has no shortness of breath. While it's certainly possible to present with a PE with just pain, this case is just not what a PE looks like, either in its classic presentation or even atypical variations. Once we have exhausted the framework, we should do one more step before creating the differential. We should ask if there are any key features which have not yet been incorporated into the framework. That is, are there any key features which don't seem to impact the likelihood of any of the diagnoses in the framework? In this case, there are essentially three. The first is the normal troponin and CK. So why was this piece of information not incorporated into our framework discussion? It's because they were actually misidentified as key features. That is, there are no causes of 4 hours of epigastric pain in which we would expect the troponin or CK to be abnormal. Even in the event that the patient had an acute MI, it really is too soon for these enzymes to become elevated, and so therefore they probably should not be key features. The second unused key feature is the guaiac negative stool. This key feature was critical in establishing the problem representation in step 3, because had she been guaiac positive, the problem representation would not have been acute constant epigastric pain associated with SIRS, but would have been something more like acute epigastric pain associated with guaiac positive stool. This in turn would have dramatically changed the framework we came up with in step 4 and are subsequently using now. So even though we did not use the guaiac negative stool here in step 5, it was still an important element of the presentation and definitely worth mentioning. The last unused key feature is the most interesting. It's the history of the newly drilled well. Depending on where you are in your training, this probably did not occur to you, but the combination of acute abdominal pain, nausea, and possible contamination of well water is all consistent with heavy metal poisoning, specifically arsenic and lead. This brings up an important point. If an element does not fit into the framework, yet still seems to be a key feature, the framework must be incomplete. In this case, I would add another category of diagnoses to our 4 existing categories of epigastric, right upper quadrant, left upper quadrant, and chest. That 5th category is acute abdominal pain secondary to systemic toxic metabolic problems. That is, acute abdominal pain that does not cleanly map to any one specific organ. The four major members of this group are heavy metal poisoning, a rare genetic disorder called acute intermittent porphyria, another rare genetic disorder called familial Mediterranean fever, and finally angioedema. For any of these to be the final diagnosis, this patient would need to have an atypical presentation of a rare disease, and thus it would be a highly unlikely diagnosis, except for the fact that the patient has this unusual key feature of the new well that suggests the first item on the list. So should we keep heavy metal poisoning under consideration? Possibly, at least for now. You need to figure out more about this well and its relationship to industrial activity near her home in the mountains. If there is or was an active mine nearby, then I would definitely still consider it and would try to arrange for the water to be tested if an alternative diagnosis was not immediately secured. However, in the more likely case that there was no mine or other unusual industrial activity near her home, this can probably be crossed off the differential at this point. Also, if the patient's pending CT scan showed clear evidence of an alternative, more prevalent diagnosis such as pancreatitis, for example, that would also be sufficient to cross off heavy metal poisoning. In the interest of completeness, I have not mentioned the diagnosis of diabetic ketoacidosis, which can definitely present with acute abdominal pain and nausea in a diabetic. However, the normal metabolic panel, which implies a normal glucose, completely rules out this possibility. So after all of this discussion, what's our differential diagnosis? To answer that, we need to decide which combination of arguments for and against the diagnosis based on the key features results in the most likely possibilities. Remember in part 1, I mentioned that the skill needed here is the single aspect of clinical reasoning which I think most sets apart experts from novices because it requires more than just textbook knowledge. It also requires knowledge of the scientific literature, lots of first-hand experience with a wide variety of diagnoses, and the ability to qualitatively apply the principles of biostatistics on the fly. In my opinion, the most likely diagnosis for this patient is acute pancreatitis. If we bring back the key features for this, we see that pancreatitis is associated with her heavy alcohol use. It explains her nausea, her distress, the vital signs, her tenderness on exam, leukocytosis, and is the best explanation for the elevated lipase. The only key feature arguing against it is the fact that the pain is not made better or worse with changes in position, which, as I suggested earlier, is not likely to be a highly sensitive or specific finding. In addition, pancreatitis is a relatively common diagnosis among patients presenting to the ER with abdominal pain. Overall, this is a relatively classic presentation of a common disease, and therefore our leading diagnosis, also known as the provisional diagnosis. In addition to the provisional diagnosis, the other categories of diagnoses which belong in the differential are those conditions which are common and for which this could be either a typical or atypical presentation, those diagnoses which are rapidly fatal if missed, for which this could plausibly be a presentation, and finally, any diagnosis that is specifically suggested by an unusual element of the presentation, even if the diagnosis itself is rare. Common disorders for which this could be a typical or atypical presentation include gastroenteritis, food poisoning, and either gastritis or peptic ulcer disease, which I have grouped together because I think it's very difficult to tell the difference between them without endoscopy. Don't miss diagnoses for this presentation would include a bowel infarction and acute coronary syndrome. And finally, an unusual feature diagnosis is heavy metal poisoning related to contaminated well water. Remember that the differential should be listed in descending order of likelihood, and I don't mean to suggest that the various categories of diagnoses always or even usually map out as neatly as this. Also, this list only represents my opinion. I have no doubt that if a dozen of my outstanding internal medicine colleagues were to watch the case presentation and were then asked to write a 6 to 7 item differential, none of the lists would be completely identical. For the most part, the greatest degree of agreement involves the provisional diagnosis, and as you move further down the list, ideas start to diverge a little bit. I would certainly expect most experienced doctors to identify pancreatitis as the leading diagnosis in this case.
So that concludes part 2 of 3 of this video series on the clinical reasoning. I hope you found it interesting and useful. While the approach I presented here is not the only one in use, I guarantee medical trainees that if you consciously employ it while on the wards, you'll impress your peers and evaluators, and more importantly, create a more accurate differential that will increase the likelihood of establishing the correct diagnosis sooner in a patient's hospital course.